Hey everyone, and welcome to Bioscan Hub. Iron studies, they're one of those things that seem so basic, but man, they can get confusing, right? Well, today, we're going to change that. We're going to build this super clear, logical framework, so by the end of this, you'll be able to look at these results and feel totally confident decoding whatever anemia comes your way.
And hey, if you're a student in the medical field and you're trying to really master these complex lab topics, you have landed in the perfect spot. Do me a quick favor and hit that subscribe button. It seriously helps us out and lets us keep making these deep dives for you.
All right, let's just jump right in with a classic scenario, something you're going to see all the time. A patient walks in, they're tired, they look pale, your brain immediately screams anemia. So you know you've got to order some labs, but what exactly are you looking for? Where do you even start? This right here, this is ground zero for our entire investigation. So, to get to the bottom of this, we're going to follow a really clear path. First, we'll tackle the core iron panel. Then, we'll dig into ferritin, which is like the body's iron savings account. After that, we'll look at the gold standard test for when things get a little murky. Then the fun part, putting all the clues together to decode different types of anemia. And finally, we'll even touch on what to do when iron isn't the bad guy.
Okay, let's kick things off with Section 1, the core iron panel. I want you to think of this as our first peek at what's happening right there on the front lines. The iron that's actually circulating in the blood and all the key players that are managing it. So first up, we've got transferrin. This protein is just absolutely crucial. The liver makes it, and its whole job, its only job, is to grab onto iron and move it safely through the blood to wherever it's needed. Like the bone marrow, which is busy making new red blood cells.
You know what? Let's use an analogy here. It makes this whole thing so much easier to remember. Let's imagine your bloodstream is like a big, bustling city. And in this city, all the transferrin proteins, they're basically just taxis driving around looking for a passenger.
Okay, so if transferrin proteins are the taxis, what's serum iron? Well, that's just the number of passengers, the iron atoms themselves, that are actually riding in those taxis at any given moment. It's a snapshot of how much iron is in transit right now.
All right, now let's zoom out a bit to the bigger picture with something called TIBC, or total iron binding capacity. Now, in our little city analogy, this isn't about the taxis that are full. This is the total number of seats available in all the taxis in the whole city, whether they're full or completely empty. It's a measure of the body's maximum potential to carry iron.
And this is where it all clicks into place. We can calculate the transferrin saturation, which basically tells us what percentage of all those available taxi seats are actually filled up. It's a simple calculation. You just take the serum iron, that's our passengers, divided by the TIBC, our total seats, and then multiply by 100. That percentage gives you a way more accurate picture of the body's iron status than just looking at serum iron by itself.
Okay, now for a super important pro tip, especially for you guys heading into the field. Getting an accurate result here is all about getting a good sample. It's the classic garbage in, garbage out scenario. So, a few things to remember. Iron levels naturally change throughout the day. They're highest in the morning, so that's the best time for a blood draw. If a patient just had a transfusion, you've got to wait because their iron levels will be artificially high. And you have to be so careful about hemolysis. If those red cells break open in the tube, they spill out all their iron and your result will be falsely high. Oh, and one more thing. Be aware that things like estrogen therapy can actually increase transferrin production, which messes with the TIBC, so that always has to be noted. Seriously, following these rules is just critical for accuracy.
All right, so we've looked at the iron that's out and about, circulating in the blood. But what about the reserves? It's time to go check the body's savings account.
And that savings account? That's ferritin. See, ferritin isn't about transport, it's all about storage. This protein's job is to safely tuck iron away inside the cells. And because of that, measuring the ferritin level in the blood is hands down the single most reliable indicator of your patient's total iron status. It's way more sensitive and specific than those other tests we just talked about.
Okay, listen up, because this number is huge. If there's one value you burn into your brain about ferritin, make it this one. A level below 10 nanograms per milliliter, that is a critical finding. It is so specific for iron deficiency anemia. It's basically the lab's way of screaming that the body's iron stores are completely empty.
But, and this is a really important but, here's a huge clinical pearl for you. While a low ferritin is super straightforward, a high ferritin is way more complicated. Yeah, sure, it can mean iron overload, like in hemochromatosis, but here's the catch. Ferritin is also something we call an acute phase reactant. What does that mean? It means the body just starts pumping out more of it in response to inflammation.
So you can see high levels during an infection, with liver disease, or even some cancers, and it might have nothing to do with the actual iron status. Figuring that out is absolutely key when you're making your diagnosis.
So what do you do when the blood tests are, well, kind of confusing? Like maybe the ferritin is normal or even high because of some inflammation, but you still have this gut feeling that there's an iron issue. What's next? Well, that's when we bring out the big guns, the most definitive test we've got.
And that is the gold standard, the Prussian blue iron stain, done on a bone marrow sample. And why is it the gold standard? Because you're not messing around with proxies in the blood anymore. You are looking directly at the iron stores right inside the body's red blood cell factory. If you can see stainable iron in that sample, boom, you can definitively 100% rule out iron deficiency. It is the ultimate tiebreaker.
So when you're looking at this stain, what are you actually looking for? You're hunting for these specific cells called sideroblasts. They're just immature red blood cells, normoblasts, that have these little visible iron granules inside. In a healthy person, you'd expect about a third of these developing red cells to be sideroblasts. It's the perfect sign that iron is available and it's being used correctly.
And this is a great look at what you'd actually see. So in something like iron deficiency anemia, or even the anemia of chronic disease where iron just isn't available, you'll see very little or even zero blue staining. But on the flip side, in conditions where you have iron overload, like hemochromatosis, or in anemias where the iron is there but the body can't use it right, like thalassemia, well, you're going to see a ton of that blue staining, a dramatic increase.
All right, this is the moment we've been building up to. It's time to put all the pieces of the puzzle together. Each test we've talked about is a clue, and when we assemble them, we can finally see the whole picture and start telling these different types of anemia apart.
Now, this right here highlights one of the biggest challenges you're going to face. Take a look. Both iron deficiency anemia and anemia of chronic disease can start with a low serum iron. So how do you tell them apart? The other tests tell the real story. In iron deficiency, the body is desperate for iron, right? So it starts making more taxis, the TIBC goes up, but the storage tanks are empty, so ferritin is low. Now, in chronic disease, the body is actually hiding the iron away as an inflammatory response. So it doesn't need as many taxis, TIBC goes down, and ferritin is normal or even high. This pattern, you have got to know this pattern.
Okay, let's expand on that a bit. This table is an amazing summary of the patterns you'll see out in the real world. Just look at the everything is down profile for iron deficiency. Super clear, right? Now contrast that with the mixed up picture you see in chronic disease. And then you've got this whole other group over here. Hemolytic anemia, sideroblastic anemia, thalassemia, where the body is basically overloaded with iron, either because red cells are breaking down too fast or because the iron just can't be used properly. And in those cases, look, everything is usually up. Getting these patterns down is just fundamental.
But what happens when the iron studies just don't fit the picture? What if you've got a patient who is clearly anemic, but their iron panel looks, well, pretty normal? This brings us to our final, really important section, remembering that anemia isn't always about iron.
So when you start suspecting the problem is with the actual hemoglobin molecule itself, your go-to test is going to be hemoglobin electrophoresis. It's a pretty cool test. It basically uses an electrical field to separate out all the different types of hemoglobin. This lets you spot the abnormal ones, like hemoglobin S in sickle cell, but it also lets you measure the amounts of the normal ones, like A2 and F, which is absolutely essential for diagnosing conditions like thalassemia.
And that brings us right to our final thought, a real clinical puzzle for you. Imagine this. You have a patient with small red cells, a classic microcytic anemia. And your first thought is obviously iron deficiency. But then you run the panel, and their iron studies come back completely normal. So what should be at the very top of your list of possibilities? Thalassemia. It is a classic presentation, and it's the perfect reminder that a great diagnosis means looking beyond the obvious and always using the right tests to find the real story.